lumbar puncture and your CSF examination. It's an important step, important invasive procedure, little bit invasive, not that, don't be afraid of, because why do you do it? The meningitis, encephalitis, tubercular meningitis, and few more leukodegenerative disease, you need to do it. On emergency basis, you need to do it for bacterial meningitis mostly. So, and some demyelinating disease, you need it at times, good amount of time. The contraindications must be known before embarking into the procedure. The contraindication is the raised intracranial pressure. So, commonly due to the cerebral edema of state infections, and there can be mass lesions. So, do an ophthalmoscopy and see whether there is any papilledema. Rarely you do need to have a CT scan. Most of the time, ophthalmoscopy and the papilledema is good enough to say yes or no about the raised pressure. You do not have it normal, no papilledema. You go for the doing it. You identify the lumbar 4 and 5 space in the grown-up child. In the younger kids, you can do it a little bit upper space because spinal cord ended on the in the in side. So do commonly in children lumbar 4 and 5 because the spinal cord is a little bit lower in the younger setting. In the upper age group, it is on the up to the third space. So you can do in the lumbar of 3, and so you've identified these points by the highest point of the iliac crest, meeting the L3 and L4 and 5, and we do with the saline set. 21G is good enough. 23 may be used, and then the younger kids and the little bit grown up kids, and then you clear this in the aseptic all asepsis measures. You put the needle into that and hold the child a little bit gently, and when you feel the prop or the light resistance, you have passed the durameter, and you go a little bit not too far. If you go too far, there will be the traumatic hemorrhagic CSF that will impair your understanding the CSF data, and so stop there. And what do you really see over here? You see the more protein in the bacterial meningitis, little bit of very high protein. You don't have much protein over there in viral meningitis and then encephalitis and tuberculosis. Yeah, I do see the visibly the bacterial meningitis. They have purulent the turbid CSF, and in the viral in the you have clear crystal clear. In the tuberculosis you have little bit of your what do you call it straw colored CSF. So if you analyze, you will have raised protein more in the bacterial and your tuberculosis also. And cell count, if you have polymorphinal leukocytosis in bacterial, you have lymphocytic predominance in the tuberculosis. Viral, you can have a little bit of lymphocyte. Normally, you have 5 lymphocytes per ml, and glucose is almost zero and very low in the tuberculosis. And other neurometabolic or the demyelinating disease, they have their own data, respective amino acids and other issues. And so, treatment of those bacterial cases, you have immediate IV injection in meningitic dose subtraction, meropenem, and other preparations, depending upon the local choice, disease choice, and so forth. And so, give it for 10 to 14 days, and other supportive care in tuberculosis, antitubercular, and beef steroid to prevent adhesion between the layers of meningitis and reduces the your hydrocephalus and other supportive measures for the respective disease.